Hi everybody, my name is Michelle Tavkar. I'm a categorical intern at the University of Louisville, and I will be presenting on immunotherapy-induced hepatitis in the setting of metastatic melanoma. So first, a little background on our case. This is about a 60-year-old white male with past medical history of BPH, hemorrhoids, cataracts, and melanoma, removed in 2014 from his right shoulder with wide local excision with clear margins. He did not receive adjuvant therapy at that time. So he presented in September 2020 for worsening nausea, stomach aches, and a 20-pound weight loss. He denied any bleeding symptoms or swallowing difficulty at the time. He was admitted to an outside hospital where CT showed bilateral adrenal nodules measuring 4 by 4 centimeters. Biopsy of these nodules showed metastatic melanoma. EGD done after that also proved to be metastatic melanoma in the stomach. They did a staging MRI at the time, and radiation oncology was consulted and radiated the patient inpatient. He also was eventually started on a combination therapy of ipi/nivo in an outpatient oncology clinic on 12/3/20. Prior to his first dose, his LFTs, bilirubin, and hepatitis panels were unremarkable. Of note, he did have a liver biopsy for mild transaminitis about 5 years prior. He was told that it was periportal fibrosis, but no formal diagnosis of cirrhosis. Then he followed up in the clinic. He was on a decreased steroid taper, given his second round of ipi/nivo on 12/23/20. He was found to have mild transaminitis at the time of the second cycle of treatment, and at this time he actually decided to get a second opinion from another cancer center, and repeat staging scans were repeated at that center and showed worsened transaminitis with AST 95, ALT 330. The patient's dexamethasone was increased, and mycophenolate was added to escalate treatment of the autoimmune hepatitis from his immunotherapy. After 2 weeks, his LFTs began to downtrend, and he was able to resume an alternate immunotherapy regimen. So most of the cases of immunotherapy-induced hepatitis are asymptomatic and caught on routine lab monitoring. The majority of the side effects are seen about 8 weeks after, and it's very important to monitor these with CBC, CMP, and TSH with every infusion. This patient was showing signs after one cycle, and although it wasn't severe enough to stop the therapy, it was still essential to continue to monitor. You also need to watch out for viral hepatitis, HIV, CMV, medications, and other herbal supplements that could also be contributory to this. So the most important thing is to decide whether or not you need to hold immunotherapy and what you're going to do about it. So when deciding whether to hold it or not, you'll need to look at the grade, and there's a figure 2 actually shows you how to differentiate the grades. Anything above a grade 2, you'll have to hold systemic therapy. The next decision is actually how to treat it. The first choice will always be glucocorticoids, but unfortunately there's weaker data supporting these next options if the patient isn't having a robust response to the glucocorticoids. There's multiple case series that support different agents, and the choice ultimately comes down to provider preference. But it is important to get the next agent started as quickly as possible. Unfortunately, in this case, this patient wasn't started on another regimen for 3 to 4 weeks after the transaminitis occurred, and that actually caused, the cancers to progress because he was off of his immunotherapy at the time. So it is really important to escalate therapy within days if labs don't begin to downtrend. So this is just a case about, although it can be uncommon, these immune checkpoint inhibitors as primary therapy can cause some complications, and it's very important to monitor them, and more importantly, that if you do catch them, to escalate therapy as quickly as possible. Thank you so much for listening.